presented to OPD with the complaints of generalized swellings in the body for the past 3 years with darkening of skin in the past 3 years. Apparently, 3 years back when she started noticing swellings in the body, first noticed left side neck swelling progressively increased in size in about a year and remained stable for the next 2 years. And also other sites such as axilla and neck, she has noticed similar swellings. The swellings were painless, not associated with redness or warmth. There was no history of fever. She also complained of darkening of skin for the past 2 years, started on the face, extended to involve the entire skin, entire body. Associated with it, she also developed excessive hair growth, which was noticed predominantly in the upper limbs as well as then a lesser degree in the lower limbs as well. She also had irregular menstrual cycles for the past 3 years. There was also a history of tingling sensation of the soles and palms with numbness, burning sensation, occasionally with the feeling of heaviness in the limbs. There's no history of positional giddiness, altered bowel habits. There was no bone pains, no night sweats, no evening rise of temperature. Past history wise, recently, 1 year back, she was diagnosed with hypothyroidism, hyperuricemia, dyslipidemia. No prior known comorbidities, no surgeries, no hospitalizations. Personal history, there was no substance abuse, smoking, alcohol, sleep, bowel, bladder were normal, no high risk behavior. There was significant loss of weight of 20 kgs in the past 4 years with loss of appetite as well. There was no similar illness in the family, no hematological disease, no contact of TB in the family. On examination, the vitals were normal, and on the general examination, clubbing of nails in the fingers, grade 2 was present. Lymphadenopathy was present, supraclavicular nodes bilaterally palpable, bilaterally axillary nodes were palpable. The nodes were firm, non-tender, and discrete. The left supraclavicular node was 2 cm in size. The left axillary lymph node was 1.5 centimeters in size. The skin findings noted were that there was edema, bilateral upper limbs and lower limbs, symmetrical, and it was firm. Upper limbs are noted to have thick, leathery skin with a prominent hair follicles, giving a pretty orange appearance. There was hyperpigmentation diffusely noted, more prominent over the extremities, giving a dusky appearance, and also over the neck and upper back. There was thickening of skin, as mentioned before, in forearms, hands, and feet. There was also noted hypertrichosis over the bilateral forearms and bilateral necks. The palms and soles, there was increased hyperpigmentation of palmar crease. Thyroid was palpable diffusely and it was soft. This was the picture of arm. I'm not sure if it is very clear. If you look closely, there is hypertrichosis, which we can note, and there is prominent hair follicles, which we can note. And in a real picture, we can notice the hard edema as well. On systemic examination, cardiovascular, respiratory, and were normal. For abdominal examination, liver was palpable 5 centimeters below the right costal margin, and top space was dull. On the central nervous system examination, higher mental functions, cranial nerves were normal. Motor examination was normal. Sensory examination also clinically it was normal. The reflexes, cerebellar signs, meningeals, skull and spine examination was also normal. Clinical impression is a middle-aged lady from Bihar with no known prior comorbidities, comes with significant constitutional features, significant loss of weight and appetite, with a recent diagnosis of hypothyroidism, hyperuricemia, dyslipidemia, also complaints of paresthesias, and has generalized lymphadenopathy, hepatosplenomegaly, hyperpigmentation. Top space was dull. Hyperpigmentation, leathery skin with excess hair as summarization of history and examination. Putting together the features of systemic disease with multiple anatomical localization, and when we think of system-wise CNS, she has features of neuropathy, and there is organomegaly, form of hepatosplenomegaly, lymphadenopathy. The features of firm leathery skin with pretty orange appearance, the firm edema, showing features of hypothyroidism and hyperpigmentation. This suggestive of Addison's features as well. Significant hyperpigmentation with significant constitutional features with Palma crease involvements, and skin changes, significant skin changes. Clinically, we had sort of Poem syndrome, but since she has significant constitutional features and multiple organ involvement, the differentials to consider and to rule out infiltrative disorders, amyloid histiocytosis, hemochromatosis, plasmacyte disorders, sarcoid, infective disseminated TB, HIV, histoplasma, malignancy, hematological, firstly plasma cell disorders, lymphoma and leukemia. Initial investigations wise, the blood picture, liver function test, renal function tests were normal, electrolytes were normal level. The endocrine workup, thyroid TSH was very elevated with a FTC of 0.73, low FTC. Calcium phosphate was normal, HbA1c was normal. ACTH baseline was elevated 81 with a low 8am cortisol and with no response to synactin. Post-synactin was 15.3. EMG had shown features of sensory axonal polyneuropathy. Electrophoresis had shown a normal pattern. Further investigations in view of the considered differentials, bone marrow had shown a normal hematopoiesis trilineage, and the culture for bacterial as well expert was negative. It has shown plasmacytosis of 7%, and the beta-2 microglobulin in view of my plasma cell dyscrasias was done was elevated. Left supraclavicular node showed Castleman's disease features, and the possibility of mixed or plasmacytic subtype was given. It was also for expert negative. CT thorax abdomen done in view of systemic disease as well as to look for any osteolytic lesions, showed a lytic expansile lesion in the first strip as well as D1 vertebra, and the supraclavicular bilateral axillary nodes as clinically felt. Hepatosplenomegaly was there, but there was no focal lesions, there was no features of an infective process. A detailed lymph node biopsy, I'm just highlighting few things: endothelial venular proliferation, sheets of plasma cells, lymphoid follicles, and lollipop-like lesions, arteric lymphoid follicles, interfollicular moderate plasmacytosis, CD138 stains positive, suggestive of Castleman's disease, a lymphoproliferative disease. So final diagnosis at the end of the evaluation was a Castleman variant Poem syndrome, which fulfills the criteria with underlying endocrinopathies with primary adrenal insufficiency and hypothyroidism. I want to add a few slides on the Poem syndrome. Poem syndrome in our patient, there are three criteria: mandatory, major, and minor. She had fulfilled two major mandatory, that is peripheral neuropathy and plasma cell disorder, as well as major criteria. It's actually 2+. She had also fulfilled sclerotic bone lesion, Castleman disease, and VEGF level was awaited. Minor criteria, there was endocrinopathy, skin changes, organomegaly. Poem syndrome is a paraneoplastic syndrome, polyradicular neuropathy, organomegaly, endocrinopathy, monoclonal plasma cell disorder, and skin changes. Few things to note is that not all features may be present in Poem syndrome. Other things which we can see is papilledema, extravascular volume overload, thrombocytosis, and erythrocytosis. And the Castleman's disease variant of Poems may be associated with clonal plasma cell disorder, different variant. Initially, a lot of patients were diagnosed in Japan. It was around 1980s, but later on, all over the world, Poems picture was seen, and the Japan survey in 2003 showed a prevalence of 0.3 per 1 lakh population. Here, the characteristic findings: polyneuropathy and polyneuropathy and monoclonal plasma cell dyscrasias are mandatory, so there will be 100%, and that is blue colored. And coming to orange color, bone lesions, which comes under major criteria. Castleman's disease, sclerotic bone lesions, VEGF are major criteria, and the green dots are minor criteria: organomegaly, extravascular overload, endocrinopathy, skin changes, papilledema, thrombocytosis. These are the percentages, prevalences which can be seen, out of which endocrinopathy is 60 to 80%, out of which gonadal axis is more affected and less likely, and lower down the order is adrenal. And the other skin changes are quite significant, 60 to 80, whereas papilledema, extravascular overload are lesser. around 30 to 60, 30 to 80 percentages. And one thing to consider is that to differentiate poems with monoclonal gammopathy of unknown significance and splintering and multiple myeloma, because the treatment varies and the follow-up varies and the prognosis varies. Other features which things to note is that in the blood picture, they are high risk for thrombosis. They may have thrombocytosis and plasmacytosis. VEGF levels are not dependent on the M protein size. VEGF levels, which correlate with the treatment as well as to prognosticate, they are not dependent on the M protein. In our patient, the electrophoresis was normal, IFE was normal. Neuronopathies, the axonal variety is greater than CIDP, which is differentiating factor. And endocrinopathies, most common is hypogonadism. Then comes thyroid, diabetes, glucose metabolism, and lastly adrenals. Pulmonary involvement can be seen in form of pulmonary arterial hypertension, restrictive lung disease, neuromuscular respiratory dysfunction, and also impaired diffusion capacity. Renal-wise, it's not much known. It was seen that serum creatinines are normal, but cystatin was elevated, but there was no significant renal dysfunction noted. And Castleman's and poems, it's a different variant in the poems considered. Castleman's disease as such is a lymphoproliferative disease. When it comes along with poems, the symptoms can range from simple B symptoms to various autoimmune phenomena to frank poem syndrome. And the neuropathy in the Castleman's disease associated with poems may be subtler than other poems variants. Thank you.
I just have one question. How did you treat your patient? I mean, what happened to your patient?
The patient, we had asked hematology consult. They had opined for follow-up of VEGF levels, and they were planning to give cyclophosphamide, bortezomib, and dexamethasone, followed by autologous stem cell transplant. That was suggested.
What about the endocrine abnormalities? Did you correct?
Yes, we have corrected with replacement steroids with thyroid replacement as well.
Patient is better slightly?
Patient is better. It's transferred to hematology.
What is the percentage of plasma cells in the arrow? 6%.
7 cells, sir.
But there is plasma blasts?
There were no blasts.
And electrophoresis is normal.
Electrophoresis is normal. And there was osteolytic lesion in the first rib. Probably another source of a plasma cell lesion, which
BJP, like everything is negative.
negative, so immunofluorescence.
Plasma cell is
Here,
borderline elevated.
borderline elevated. In view of Castleman's proven in the lymph node, it was considered, so Castleman's variant of poems.
What is the radiology like? Second question, just put the cortisol electrolytes. What is the serum electrolytes? 141. So if the ATM cortisol is 11.5, is normal blood pressure, normal electrolytes. Why would you do a post-analysis and how do you do the analysis?
So taking 18 and below to be significant.
8 to 25, no? Your ATM cortisol is.
Yes, ma'am.
The ATM is within the normal.
Yes, sir.
Very wide range. Now, ATM is something like 10 to 20.
25, yes, sir. Yes, 8 to 25.
I was of the impression that to consider 18 and below with the clinical map. Post. I'll just check on if there was another previous value, probably after cortisol. I'll check.
So it's almost like multiple myeloma.
Yes, sir.
Plus all that supplement.
All the endocrine, they're attributed to the vascular and lymphoproliferative disease process for which the replacement is the treatment.
Let's show that photograph of that schema.
This is The left forearm though.
Okay, thank you, Dr. Pranuth. Dr. Birila had to leave due to an emergency, and she had recommended that the prize be given to Dr. Vyas.